invite our chairpersons for the first session on interstitial brachytherapy in carcinoma cervix to the dais. Professor Dr. N Senapati sir, Professor Dr. Niharika Panda, Professor and HOD, Department of Radiation Oncology, AHPGIC Cuttack, Professor Dr. Bhagyalaxmi Nayak, Professor and Head, Department of Obstetrics and Gynecology, AHPGIC Cuttack. I would like to call upon stage the presenter for the session, Professor Dr. N Sharma. Professor Dr. N Sharma is Head, Department of Radiation Oncology, AIIMS, New Delhi, and National Cancer Institute, Jhajjar. To his credit, he has more than 200 research papers in national and international journals and is also a leading international expert in brachytherapy. Now I would like to hand over the session to our chairpersons.
Hello. Hello.
Topic. And we are fortunate with us. Professor N Sharma is there. He is a very well-known face in our community. N Sharma is the professor and head at Department of Radiation Oncology, AIIMS, Bhubaneswar. And, AIIMS, New Delhi. And Dr. Sharma has a lot of contribution, particularly in field of brachytherapy. So we are very fortunate that Dr. N Sharma is with us. So let me invite Professor N Sharma, and his topic is Interstitial Brachytherapy in Carcinoma Cervix. Over to Dr. Sharma.
Faculty chairpersons, my dear teacher, Dr. G.K. Rath, Dr. C.S. Bal, my dear colleagues, ladies and gentlemen, very good morning. Thank you, Dr. Dilip and Dr. Saroz, for inviting me. It's really a pleasure to be here and to speak on brachytherapy. And thank you once more for keeping 3 back-to-back lectures on brachytherapy, because usually brachy lectures are towards the end of a day or end of the conference, but keeping 3 lectures, just the opening session of the conference, a huge favor to the brachytherapy. So thank you once more. So I will speak on interstitial brachytherapy in carcinoma cervix, and just to give you the brief background, brachy plays an important role in the treatment of carcinoma cervix. It is, in fact, the mandatory part of the treatment in carcinoma cervix. You cannot cure a carcinoma cervix without including the brachytherapy. And that is why I never believe that you can cure cervical cancer without the integration of the brachytherapy in some form or the other. When we talk of brachytherapy in carcinoma cervix, mainly it is the intracavitary radiation treatment we deliver. But there are other forms of brachytherapy which are equally important, but they are not very well known and they are not widely practiced. And if you see the lot coming to the any clinic or the center, about 10 to 15% patients are not suitable for intracavitary brachytherapy. This is in my experience. There is no robust literature on this, but I think in our country about 10 to 15% patients are not really suitable for intracavitary radiation treatment. There can be different reasons for this. And in such patients, you'll have to perform some alternative treatments like brachy, other forms of brachy, or some other treatments. We'll just come to that. But from my side, I would say that do not replace brachy with IMRT. You will end up compromising the outcome of these patients. If you have to replace brachy, then replace brachy with another forms of brachytherapy. There are other forms of brachy, but do not replace with IMRT. And this is why the brachy is important and essential component of the treatment of carcinoma cervix. If you see the ABS guidelines, we need to deliver about 85 to 90 gray 2.0 HRCTV for locally advanced cervical cancer. That's what we see in our country. About 45 to 50 gray we deliver by XMV treatment, and rest 40 to 45 gray comes from intracavitary brachytherapy. So therefore, the contribution of brachytherapy is almost equal to EBRT. So do not underestimate the contribution of the intracavitary brachytherapy, because it's almost the same component or the same proportion of treatment you are delivering with the brachy. And more so, the chances of error in EBRT are not really much. As Dr. Rath always says, if you treat a carcinoma tongue, treat the entire oral cavity. The tongue is not going to go out oral cavity. Similarly, if you include the entire pelvis, you are mostly covering the primary tumor, the parametria, and the nodes. What is important is in brachytherapy because it is very subjective. I've seen even sometimes my senior colleagues struggling with intracavity brachytherapy. So it is an art which is to be mastered, because if you want to cure carcinoma cervix, the ICRT has to be accurate and very robust. The other reason for brachy to be essential in carcinoma cervix is because the OIRs lie very close. God has given cervix very close to the rectum and very close to the bladder. So it is very difficult to deliver the tumoricidal doses of 90 gray without incorporating brachytherapy, which has a sharp fall-off, And not only sharp follow-up, the real advantage of brachy is not sharp follow-up, In fact, in my opinion, there's sharp build-up of the dose within the target. The moment you go closer to the needle and to the tendon, the dose becomes almost 3 times, which is not possible with IMRT or SBRT. So this is the beauty of the brachy, that the dose fall-off is very sharp in the OAR and very steep gradient in the target region. And this slide I borrowed from a medical physics Dr. V. Subramani. This shows the depth dose curves of the various modalities. If you see this curve, this is the cobalt, neutron, 8 MV X-rays on LINAC, and you see the high entry dose and almost the significant exit dose, So not a good depth dose in oncology. Then you have the electrons, 20 MV electrons. Of course, the dose follow-up is sharper than the photons and the neutrons, but still you have a high entry dose, and even the follow-up is not that sharp, Then you have protons. Many people believe that protons have the sharpest decline of the dose. It is evident here that this dose follow-up is very sharp, but if you see the left-hand side of the curve, the brachy is the steepest decline of the dose, So if you have to talk of the conformity of the treatment in radiation oncology, brachy delivers the sharpest decline of the dose in the OAR. So whenever you talk of the conformity and dose follow-up, sharp follow-up, then brachy has to be incorporated in that treatment. Now the patients who are not suitable for intracavitary are actually the patients who will require interstitial brachytherapy. And these are indirectly the indications of the interstitial brachy for carcinoma cervix. There can be 2 kinds of reasons for unsuitability of intracavitary. One is the technical reasons and then the clinical reasons. Technical, when the patient has distorted anatomy in the form of obliterated os, or the patient has been operated and there is no uterus to put the tendon, and when the vagina is too narrow to accommodate either the ovoids or the ring, So these are the reasons you will require, even though patient is clinically suitable for intracavity, but you will not be able to perform the intracavitary. The other category of reasons is the clinical reasons, that when the primary tumor is more than 4 cm in size, lateral pyramid is going right up to the lateral pelvic wall, when the vagina is involved, especially the middle half or the lower 1/3, upper 1/3 you can still get with intracavitary, but the middle half and lower 1/3 cannot be covered by the standard tendon ovoid or the ring applicator. Then post-op and post-RT recurrences and patients having isolated nodal recurrences also can be treated by brachytherapy. These are the various actual indications. And when we are not able to perform intracavitary in these patients, what are the alternatives? One is the classical traditional template-based brachytherapy devised by Syed and Vipit. And most people think that the interstitial brachy is synonymous with the template brachytherapy. It's not so. We have now another form of brachytherapy, interstitial brachy in cervix, which is hybrid applicators. And this is picking up now and becoming popular as well. It's very convenient. It is called hybrid brachytherapy, which means combining the intracavitary and interstitial together. The other forms of brachy are rarely practiced, but we'll just come to that. The other option for these patients, if you are not able to perform intracavity or interstitial or hybrid, then people try to replace them with IMRT, VMAT, or SBRT. Well, in my opinion, that is not the case. In very rare scenarios, we are not able to perform any of the brachy techniques, then you can do that. But believe me, you'll end up compromising the outcome of these patients if you perform the IMRT or SBRT in these patients. Last option is surgery. Some centers have been performing surgery very rarely when they are not able to perform the intracavity, especially the French people. If you remember the stick trial, they've been doing the surgery in patients who are not fit for intracavity. So this is why you can't replace brachy with IMRT. This is one study published in Red Journal from Harvard Group in 2013, and you see patients, this was a sheer database analysis, and you see the 2 groups, brachy versus no brachy. And you see even at 10 years, the survival is way inferior to the patient treated by brachy. So do not try to replace brachy with any other forms of treatment. This is a small study we have done at our center. We compared the interstitial brachy with the IMRT. What we did that we selected 10 patients who were treated with interstitial brachytherapy, and we retrieved these CT images, and we imported onto the Eclipse treatment planning system, and we gave a PTU of around 5 millimeter all around, and we kept the same CTU for both the treatment plans, And then we threw like 7 to 9 beams for generating the IMRT plan, and then we compared the various DVH parameters to know whether the IMRT is equally good or bad. But to our surprise, the IMRT delivered much higher doses to the bladder and the rectum, although PTU coverage were more or less same. So again, just to emphasize that, the interstitial brachy is the best way of delivering the treatment as compared to the IMRT. And if you want to go into details of this paper, we have already published this data into the Brachytherapy Journal 2013. Now, to begin with interstitial brachy, there are certain key points, very important points to ponder before you start practicing interstitial brachytherapy. One, as I said, do not jump onto interstitial without mastering the art of intracavity, because certain patients, you can still get away with a simple treatment. You must believe that the interstitial brachy with template or without template is a very intricate, cumbersome, and very complicated procedure. It has certain morbidity attached to this, so try and avoid if possible. And that is possible if you know the skill of doing the ICRT. It is still a simple treatment, convenient treatment for both the patient and for the caregivers. Select patients of interstitial brachy very carefully and counsel them properly. Select patients who are likely to benefit from it. Otherwise, the interstitial brachy will blame that it could not cure these patients. So select patients very carefully. Use combined spinal epidural anesthesia, because if you put 20 needles into the pelvis, definitely it's going to be very painful, So you have to make these patients very comfortable, otherwise they are not going to come back to you for next fraction or next session of the brachytherapy. Select the applicator very carefully. In some patients, you may not use the template brachytherapy, which is slightly intricate. You can select the hybrid applicators, which are available nowadays, and you can make it a little convenient to the patients. This is one thing I strongly believe, that if you want to practice interstitial brachy for carcinoma cervix or for any pelvic malignancy like prostate or any other malignancy, you will have to use a real-time imaging in the form of ultrasound, especially the transrectal ultrasound. Or nowadays we have mobile CT scan, where you can take this mobile CT scan into the operation theater, and you can do the imaging there and then, and you can rectify your implant there in the OT itself, And then the image-based planning. You can do nowadays, most brachy plannings are image-based, volume-based plan. So incorporate either CT-based plan or MRI-based plan, or even now we are at our center are doing in some patients even PET-guided IMRT planning for carcinoma cervix as well. Just to show you that, in some patients it is not easy to perform intracavitary. Like you see, the first example is the retroverted uterus, and our tendency is to put the tendon like upwards and straight, So you'll end up perforating and putting the implant in the wrong way. Second is hyperantiverted uterus. These are not very uncommon scenarios, You will end up, you will find these scenarios quite common in your practice, So if you're not able to do that, you'll definitely jump onto the interstitial brachy. But I tell you, there are ways and measures to put the implant into the correct place, even with these kind of distorted anatomies as well. And therefore, you can avoid the interstitial brachytherapy in these patients. There are 4 kind of techniques for delivering interstitial brachytherapy in carcinoma cervix. One is the classical, as I said, traditional template-based brachytherapy, then applicator-based, freehand implants, and then the IoT or intraoperative high-dosage brachytherapy-based implants, The first one is the Vienna applicator, where you can put the needles into the ring, and you have a tandem also, of course, and then you have ring as well. And then second is the Rotterdam or uterate applicator, in which you put through the ovoids, you can put the needles. This is the one, so you can put the needles through the ovoids. Then we have the classical Mupit and Syed, the pioneers who originally devised these templates. And nowadays we have even Venezi applicator, which is MR compatible, and with this you can perform intracavitary, interstitial, combined, hybrid, every kind of brachy you can perform with this. Only thing is that it is MR compatible, and this is really costly and not easily available as of now in the market. This one first example is the hybrid applicator based brachytherapy, where you have the central tandem and you have the ring, and then in the ring you have 6 needles. And you see the tumor, you can see the tumor very clearly. This is mainly for patients where you don't have the parametria and you have the large primary disease on the cervix, which you cannot cover with intracavitary. So with this arrangement, you can cover the primary tumor very nicely. And although, since this is an MR compatible applicator, you should do the MR, but if you don't have the MRI, doesn't matter. You can still do the CT scan, because this MR compatible applicator does not pose artifacts into the imaging, and you can still clearly see where is your target. But this hybrid applicator has certain limitations. It has a very high cost. It's easily breakable. This, since it is made of the carbon fiber or the titanium, availability is also very limited. Although this is MR compatible, then you have all the nuances and the limitations of the MR, like availability, cost, and time, and etc. Our physics colleagues sometimes struggle in doing the commissioning of the MR compatible applicators. So that's also another hurdle. Clinically, hybrid may not be applicable for certain group patients. For example, the patients where the disease is right up to the lateral pelvic wall, you can't cover that disease. Patient where the os is obliterated, which means without putting the tandem, you can't practice the hybrid applicator. And the patients who are having narrow vagina, because ultimately you still have to put the ring into the vagina. So these are the practical clinical limitations where you cannot use the hybrid applicator. And just to show you the comparison of the hybrid applicator and the template brachytherapy. This is the hybrid applicator where you can just cover the primary disease. You cannot cover the lateral perineal disease. But in classical template-based brachytherapy, you can go right up to the lateral pelvic wall, and you can cover any disease which is going up to the lateral pelvic wall. So ideally, the template brachy is way better in terms of dosimetry. The hybrid brachy dosimetry does not match the template brachytherapy, but then you can select according to your desire and the scenarios. This is one of the freehand implants which I have done. The patient had a nodal recurrence, and I just put 3 or 4 needles into the target under the CT guidance, and then we created a dosimeter, and you can see how nicely it just looks like the SBRT, you know. So sometimes even with simple freehand, non-template, non-hybrid brachytherapy, you can simply get away just by putting 2 or 3 needles under the CT guidance, and it's easy. The other patient where this patient had a very narrow vagina, and we could not do template brachy because the patient was not fit for anesthesia. So what we did, we put a central tandem, and then I put 2 needles on either side under the local anesthesia, and then we loaded the various needles and the tandem, and as you can see, you're almost getting the pear-shaped dose, you know. So it's just like ideas, innovations. I didn't see this kind of picture in the books, you know, but I just got an idea that why not put 2 needles on either side and just create a dosimetry which looks like pear shape, you know. So even freehand implant can be sometimes very handy and very simple, and I term this as interstitial ovoids because it looks like ovoids, you know. This is another rare technique of brachytherapy which is not available widely in this country and across the globe. Courtesy Dr. Rath that we had this facility of intraoperative high dosage brachytherapy at our center. Of late it's not functional, but let me tell you, in certain patients it's really, really useful, especially patients who are post-RT recurrences and there's no other way to treat these patients. You operate these patients, especially like exentration, and then you place your applicator just at opposing the tumor bed. Like in this case, our surgeon has done the exentration, and the lateral pelvic wall was slightly doubtful for the positive margins, and then we place this applicator called fibrous applicators, and we connect to the machine, and just notice that, you know, there is no OAR near to this tumor bed, you know. All the organs have been displaced up into the pelvis. So that's the best scenario, that you don't have any OAR near to your tumor bed, and you just treat the patient there and then inside the operation theater, and you can deliver like 12 to 15 gray, and then rest you can combine like 30 or 40 gray by the external beam treatment. So this is another one very important treatment, especially for post-RT recurrences, you know. Now let's come back very briefly to the template-based brachytherapy in cervical cancer. I usually do not do interstitial brachy for carcinoma without the ultrasound, which is very easy. It's a simple, easily available imaging tool. It's non-ionizing. It gives you real-time 4D image. Unlike CT and MR, it gives you real-time image, you know. It's very cost-effective. And I think every center must have this facility if you are trying to perform the interstitial brachy for carcinoma cervix. In fact, with this, you can do multiple implants. You can do cervix, you can do breast, you can do prostate, and so many other abdominal malignancies. And I don't know why, sometimes I wonder, and I sometimes had this question to Dr. Rath, that, you know, when every center can procure a linear accelerator worth 25 crores, why can't we get a facility like this ultrasound only for like 50 lakhs or so? So it is very easy, and let me tell you, it is very, very useful in your brachy practice. This is the machine which we have at our center. This is slightly an older one. Now we have a newer machine as well, and this is the rectal probe which you put on the rectum. At times you can put in the vagina also if you want to see some urethral injury or some you can do a vaginal implant, so you can put in the vagina as well. And this is how the image looks like. You can see the needles, the array of needles put into the target area, and you can also see the other ones like bladder. You can see the Foley's bulb up there. This is the Foley's bulb, so you can know this is bladder, and you can see even the rectum here, and you can see sometimes the gut and in the needle. So with this, you can avoid the injury to the gut. Otherwise, if you don't have this kind of imaging, I'm sure you are definitely going to puncture the gut, and patient is going to have perforation and other complications. So with this, it's very useful, and it's very easy to avoid the puncture of just a close-up of the same patient, that you can avoid the injury to the gut with the help of the transrectal ultrasound guide images, If you want to go in details of the trust guidance for cervix brachytherapy, you can log into my paper. This was published in 2010 in Journal of Gynecological Oncology. I have a small video, but I don't think we have time. I will just, this is a video of interstitial brachy performed on a cervix patient, but I don't think we have time, so I will skip, and in fact, I will offer that if somebody is interested in this video, then please contact me on this email. I can share the video, and you will really find this useful, This is how the template procedure looks like. At the end, the 2 plates of the template and the needles and the Foleys you can see. And just like any other EBRT plan nowadays, every brachy plan is an image-based plan. So you do the CT scan, you contour the various structures like bladder, the rectum, and the target by joining the needles. And then you create the dosimetry by STR, and you can, in fact, optimize your plan as per your need. And you see how the target is being covered very nicely, and very minimal doses to the bladder rectum in this kind of scenario. So it's really very useful to do imaging for implant insertion, and then imaging for the planning here. This is the dose schedule we are following at our center. Although they are not, there is no standard dose fraction schedules, but this is our protocol. On the day of the implant, we use the truss-guided implant in the underspinal or combined spinal anesthesia, which takes around 45 to 60 minutes. And then we do CT-based brachy plan, which takes another 1.5 hours. And then next 30 minutes, we do the brachy treatment delivery. And then we remove the implant, So in all, it takes around 3 to 4 hours. And believe me, in these 3 to 4 hours, patients have the effect of spinal anesthesia lasting for this time, So they do not even know that something has been done. So if you complete the procedure within 3 to 4 hours, it is really, really very comfortable to these patients, and they don't mind coming back again for the next week session, because we usually deliver this 1 week apart. Just like ICRT, we do like 7 gray times 3, so we do 9 gray or 10 gray times 2 for these patients. So this is really comfortable to these patients, DVH parameters, I'm not going to detail, just like any other intracavitary procedure. The DVH for bladder, D2CC, 80 gray, I accept sometimes 90 gray also. These are, believe me, these are guidelines, Guidelines are just guidelines. They are not the constitution for you. So you have to modify your approach based on what you need from the particular plan. And for rectum, I usually take like 70 gray, D2CC 70 gray. This is one example I want to share with you. A patient whom we treated, this was my PhD project with sir. And this was a PET-based intracavitary brachytherapy, interstitial brachytherapy, sorry. And what we did, that we did the implant in the operation theater and took these patients for the PET scan. The reason we took the PET scan was because the needles do not create artifact on the PET image. The PET uptakes only the FDG. It does not pick up anything. So with the PET, you can really see the FDG ability, which means the tumor, unlike the CT, because if you put 20 odd needles into the pelvis, stainless steel needles, you will not be able to see any tumor there, So PET scan will really tell you where is your FDG uptake and where is your tumor. Like in this case, if you see the edge of the implant, we were thinking that we have done a good implant, but on PET scan we found that at the edge of the implant there was an avidity. So had we not done PET scan, we could have missed the target. So we have modified the target, and we included that area also in the CTV. So in some patients, I won't say that for every patient, but in some patients it's really, really very useful. Again, the dose frequency schedules, if you're dealing 45 gray EBRT, then these are the various schedules. Then if you're dealing 50.4 gray to the whole pelvis, then these are the schedules. I'd follow none of these. As I said, these are ABS guidelines based on the experience of different centers. We usually practice 8 to 10 gray in 2 sessions, 1 week apart. That's what we do. And we have published our results also in 2010 in brachytherapy. So if you want to go into the details of our techniques of implant and the outcome, then you can really see the papers. This is a systematic review of all the published literature of cervical cancer interstitial brachytherapy. And luckily, our paper also has been cited in this. And if you see, not many patients, not many series have larger than 100 patients. Most series have around 50 patients or so. And the local control has been to the tune of 60 to 70%. You must remember this, the patients where we perform the interstitial brachytherapies, they are not prognostically very good patients, Either they have little parameter disease, they either have more growth more than 4 centimeter, or vaginal involvement, that too after 50 gray of XM treatment. So prognostically, they are very poor patients, and if you don't do these kind of procedures, then they are going to fail. So 60-70% local control is a very decent outcome for these kind of patients. Of late, the toxicity has gone down because the imaging in the implant and imaging for treatment planning, dosimetry. And with this, now I would say the severe toxicity has been less than 10%, which was earlier 25-30% in the LDAR era and the non-imaging era, So this imaging, now we are able to curtail the dosage to the OAR and reduce the toxicity to these organs, To conclude, interstitial brachytherapy plays an important role in certain patients where you cannot perform the intracavitic brachytherapy. And with modern 3D image guided approach, it provides a very good local control with the toxicity which is acceptable. I would say not the minimal toxicity, but it is toxicity which is acceptable. And over the years, the toxicity has declined, courtesy again the imaging used for implant in the OT and the image-based implant. And the last message, this is the third time I'm repeating, do not replace brachy with IMRT or SPRT. You have to perform some form of the brachy, whether it's intracavity or uterovaginal or hybrid or interstitial or free end, whatever. It will still be better than your IMRT and SPRT. Thank you very much.
Any question from audience? Students? Yes, Sandeep.
Sir, thank you for this wonderful talk. As we know, brachy, as you have already said, it requires training, especially interstitial, intracavitary also, I agree. So we have very limited center who actually practically practice interstitial brachytherapy throughout India.
Right.
So sir, how do you advise to improve training of the junior and other radiation oncologists for interstitial?
Come to us for training. That's the easy answer. See, I tell you, the best way to master technique is to perform it frequently. I see some people hesitate because they see that if you do interstitial brachy with template or non-template, they are going to have morbidity, they are going to injure some ureter or blood vessel or bladder or rectum. But I tell you, this is how you gain the mastery. This is the way I was taught by my teacher, Dr. Rath, that if you to learn swimming, jump into the pool. That's the best way to learn. So if you want to learn it, you have to start somewhere. You'll have some difficulty, but believe me, these patients, if you don't do interstitial, they are going to die, I'm telling you, because they have either a lateral parameter disease after 50 gray. They have 4 cm growth, more than 4 cm growth after 50 gray. So you don't have practical options. You don't have a second chance for these patients. This is the only chance you have to do best, So start doing simple cases like where you don't have parametry, you just only have like central paracentral disease, and then you can extend up to lateral parametry and the lateral pelvic disease. This is the way to go, Rest, I do not know. I mean, this is how I learned with sir. Maybe sir can rectify whatever I told.
I think brachytherapy in general and interstitial brachytherapy in particular must be encouraged by all of us to our colleagues at this time. The reasons are two. First is the indication of the patient. See, unlike other epithelial cancers, cervical cancer beyond stage 2A, very early 2Bs are operable. So you have no other option other than brachytherapy. Because cervical cancer, as Dr. Sharma told, the first chance has to be the best chance. The first chance of cure has to be the best cure. Number one, from the patient point of view. And as I mentioned during inauguration, our specialty is facing a crisis now. I think Dr. Senapati in his presidency will address this problem also. People leaving radiation oncology going to medical oncology. Once we do procedures, you will really get interested in this art of brachytherapy. Once you go yourself and practice brachytherapy, then you will really develop interest and our specialty will get a boost, number one. Number two, is that, let me tell you, the people who practice brachytherapy all over the world, there is no place. Now I listen from people that brachytherapy, the use is coming down. See, if you don't do anything, then there is no use. You sit in the office suited, booted, and just keep ordering. But for brachytherapists who are really hardcore brachytherapists, any site in the body brachytherapy is possible, from brain till toe. And let me tell you, once you start doing it, people are afraid that there are complications. See, I don't say, we in our department don't use the word complication. We use the word accompaniment. You tell me, scar following a surgery, is it a complication? It's an accompaniment. Like Dr. Madhav, if you don't have a star, then you have to go to, a jadugar, magician. It will be there. Similarly, mucositis following radiotherapy to the mouth is not a complication. It's an accompaniment. If there is no mucositis, that is complication. Something wrong has happened. If there is no leukopenia following chemotherapy, that's a complication. So I think we should all encourage our youngsters to take brachytherapy, and as Dr. Sharma told, it is very cheap, and the feeling that with IMRT as of today can never brachytherapy. Let me tell you, proton are here. Now carbon is coming very fast. We are also trying to bring carbon to this country. Proton has a RB of 1.2, but carbon has a RB of 5. Still then, in carbon, it cannot replace brachy, because brachy gives almost 10 to 15 times dose than the, your photons. So we must encourage this. Thank you very much.
Sir, you said the dose you are giving 9 to 10 gray per fraction, 2 fraction. So have you compared with the 7 gray 3? Because many centers still practicing 7 in 3, but it's convenient for 2 fractions. So any comparison?
Okay, good question. See, if you see the dose fraction schedules for interstitial brachy, there is no standard, Many people do 5 gray times 4, many do 4 gray times 5, people do 3.5 gray into 6. So the implant duration will be something like 3 days or so, which is not easy. Let me tell you, for a patient to lie down in lithotomy position for 3 days, it's not easy, So that was the first principle we had in mind, that we'll have to make this, this is the reason why it is not widely adopted, widely popular, that patients find it very very uncomfortable, So we thought that let us make it comfortable first, So that is why we complete the process in 3 to 4 hours. And that 3 to 4 hours is actually under the effect of spinal anesthesia, because if you give anesthesia to these patients, 3 hours is the time they will have the complete anesthesia and comfort, So, and then we take out. So with this kind of fractionation, I think it's convenient to the patients, and then they don't mind coming back again for second fraction, The other reason we practice like 8 to 10 grade in 2 fractions is that, if you see the radiobiology, the largest experience of radiobiology in cervix comes from the weekly fractionation. If you see the SDR fraction, like 7 grade times 3 or 6 grade times 5, So you need to fractionate. You need to fractionate with that weekly fractionation. So that's what we do. You give like 7 grade times 3, we give like 8 to 10 grade times 2. And you see the original SDR trial, randomized control trial from PJ Chandigarh, it was 9 grade times 2, So we try to duplicate the same radiobiology. See, alpha beta of cervix will not change if you do interstitial or intracavitary, It will remain the same. Dr. Jayant will agree, he's a good radiobiologist, So that will not change. That will remain the same. So largest experience of radiobiological application in cervix comes from weekly fractionation, and that's we try to mimic and duplicate. And as per our results, I don't think it ended up very high mobility, especially with the incorporation of the 3D ultrasound in the operation theater, and then the image-based planning, and then SDR optimizing. This real combination of 3 modalities, has made it very comfortable to the patients and for us also. So it is very convenient. I would say, this is the fraction we perfected at our center, and we are very happy with that, Dr. Rahul, thank you. Intracourt, yes, that's right. Sir.
Shows a absolute survival benefit of 10% over the traditional figures which are already known. So these are the 10 to 15% patients who are actually benefiting from this image guided.
No, the publication which I showed was from Harvard group, especially when the IMRT was become, somewhere like 2007, 2006, So many of them with the hype of IMRT tried to replace brachy with the IMRT, because they thought that, admitting a patient for intracavitary and then like putting the tandem and then ovoids, it's like an invasive procedure, So they try to replace with that invasive technique with the non-invasive technique like IMRT and SPRT, And ultimately they failed miserably, So it was a mixed group of patients. I don't think it was only a patients who were not suitable for intracavitary, but it was a mixed group. Some of them, of course, they were not suitable for intracavitary. It was a mixed group, So due to that hype, many patients underwent, the IMRT, and in fact, they were insurance agencies, they were sued because of these kind of regimes, because they thought these patients were actually eligible for intracavitary, but you did not do the intracavitary. You end up doing the IMRT, which compromised the survival, So this is how.
Thank you very much, Dr. Sharma. It was really a very nice talk. Just to comment a bit about the large unmet need of this interstitial brachytherapy. I think the lesions, sometimes they really don't respond and they can't take up for any salvage surgery also. I think it does have a learning curve, but I think all the youngsters should be motivated to learn. So thank you again for the nice talk.
Thank you very much. Thank you once again.
And thank you organizers for giving us this opportunity.
Thank you, sir, for the excellent presentation. We would like to felicitate our speaker, Professor N Sharma. I request Professor Dr. N Senapati to gift a memento to Professor Sharma.